Here, another cornea procedure, a replacement of a failed graft.
What was that first part? We just saw that real quick, but that was measuring the size of the graft to know what size to make the new donor tissue?
Correct. And the failed graft means distortion in his case and edema. Here, yes, I burn the surface and this is flattening it out. That, if it's very distorted, it's very hard to get a nice, clean, round punch. And the cautery flattens that transplant so that whatever I cut, meaning whatever size I have, is actually the size. If you think it's very cut, the size that I punch will actually be much larger than I plan on.
That was an interesting thing I learned about the flattening of the cornea, because when I first saw that, I thought, well, isn't that just tightening up the tissue, making it easier to remove? Is it a dual purpose for that as well?
Dual purpose. And here I want to make sure that I have my placements, so I tend to mark, these are old RK marks, mark the center of this is the cornea to be transplanted. That's also marked so that the two marks can align. And this is just making four we call them cardinal sutures. And again, ensuring that as best I can, at least, that they're aligned. Is it perfect? Absolutely not. I'm just trying to help myself as much as I can.
So you want your new puzzle piece to fit in this place as well as possible.
Correct. And here is I previously planned, as you notice, the size. Always the donor is punched first. So should something happen, I am ready to cover that eye up again.
That's hard to see beneath the finger there, but that looked like quite a bit of suction occurring on the eye. Is that what we saw there to get it tightened on?
Correct. So I'll call it a vacuum trephine that holds it onto the eye. This then slowly rotates into the cornea. That provides a precise cut, but it is a little bit like a cookie cutter to make sure that there is a nice, round, clean cut that will then match later. You can see a little bit of fluid. That means I already entered the anterior chamber. You can see a little bit of fluid coming out there. These are scissors, that's what they're called, left and right cutting cornea scissors, that remove the patient's tissue, or in this case also the old transplant.
In that last portion where we saw the actual trephine that was cutting through, that's the same tool that would be used for a DALK, which would be partial thickness, and you're adjusting how deep it's actually going into the cornea?
Correct. And here I more base it on what I see. As soon as I see fluid, I'm done. I don't want to go any deeper. I know I'm now in the anterior chamber. Here I just remove smaller residual tissue to again make them fit as well as possible so there's no overlap.
I noticed you took a lot of care to really make that precise around the cut. Is that always necessary, this amount of precision, or is the trephine normally sufficient, or how are you knowing how much of that tissue to remove at this point?
So this, most of it is partially cut, so I'm just removing the residual, but there are some different philosophies on this. I like a clean graft-host junction because should I ever need to place a desec afterwards, meaning a tissue underneath the old graft, I like to have a smooth transition so that the desec moves over very easily. You can here see something that I don't like to see. The IOL is coming forward, meaning there's some pressure from the back, which is one of the reasons I prefer not doing full thickness transplants unless I absolutely have to, because that tissue, there's not much holding things back besides right now my forceps on the lens.
And the IOL being the lens implant behind the iris, that's after cataract surgery. Patients have a plastic lens implant, but because of that pressure, it was pushing forward, so that's being held in place. I know we're going to see the stitches here, but a question I have also as far as that cut is concerned, is it just a straight up and down cut, or is there some side to side cut? Is there a diagonal cut, or how is that cut actually being made on the donor tissue here?
On the donor tissue, there is a well that creates somewhat of a curved interface. So when the cut goes down, it's the same curve that goes in this tissue, because you saw I cut from the surface down, and so the other way is cut from the endothelium out to try and match them. It's never perfect. And again, we have healing. So that's why full thickness transplants, there's lots of healing and lots of irregularity that's induced. And this is still done by hand. The sutures, unfortunately, for now, we don't have any replacement. So cornea transplants for best vision tend to require a contact lens a lot of the times. Sometimes we get lucky and the patient have great uncorrected vision. But again, most of the time they need contact lens that gives them a more regular surface to give them better vision.
Now we have these 4 cardinal sutures being played at normal speed. I'm sure you have a little bit of a sigh of relief once those 4 are in, knowing, okay, now we just got to work on these a little bit faster speed going all the way around, and there's quite a few sutures there. How many?
Yes, so the 4 cardinals are, now we have a cover over the eye again, so should there be more pressure, so something will happen, we have a lid on basically. The other sutures, on average, yes, there's 16 on here, the 4, then 4 again, and 4 again. But I tend to replace several, some break. So I don't know how many I've placed during a surgery. I usually say enough to keep it secure. And as you can see, there are certain areas that I definitely place more sutures than others until I have a good seal. That's really what I want. The sutures can be left in for years, but they tend to be started to be removed at about 3 months.
And the curve, the shape of a patient's cornea after a graft can be evaluated with a topography, and sometimes the amount of tension of that suture is going to make it a little bit tighter, a little bit flatter, and those sutures can be adjusted and removed after surgery to try to adjust the shape of the cornea.
Correct, and you can already see here that the cornea is much flatter than it was before. Before it was bulging out, there's a much more gradual, much flatter surface, which should lead to the patients being much less nearsighted than he was beforehand.
There was a very rapid fire clip of you flipping the sutures to make sure the knot was behind and not rubbing on the eyelid when the patient is blinking.
Correct. It's called burying the knot, so the knot is always placed, for me at least, into the graft as much as I can. There's theories one way or the other. You can place it on either side. I like it because in my mind it attracts less attention from the body if it's further away. You can see some cytopositive on the bottom there. There's a little bit of what's called a suture leak that usually tends to heal within a day. But if it leaks as easily as this, meaning I push on something, as you can tell, immediately I place another suture to make sure that it is resistant to leakage with pressure when you stress the wound.
If I can go back to that for 1 second, you said bottom, but when you say bottom, you're saying inferior for the patient, meaning up in this top area here. And surgeon view, so the bottom is actually what we're seeing on the top.
Yeah, fair enough. I probably should have pointed that out. I sit at the head of the patient, meaning if I want to put up right up here, and this is my view. So looking down is towards away from me, so where that little light yellow shows up, and you can see when I push on it, there's liquid coming out of that, the anterior chambers. That's why another suture is placed to seal that area better.
And here the stitches are coming in, so patient now is extra fluorescein to check for any leakage, and it's much more intact now. No leakage of that fluid.
Correct. And there I reinflate the anterior chamber, make sure that the pressure is okay. And again, you can already see that the numbing is starting to wear off. There was a little movement by the patient. And then I place antibiotic and steroid at the end to decrease the risk of infection and control the inflammation early on.